far the other way. But I've gotten a couple emails from upperclassmen recently where they all started with, I know you're busy, but, well, almost like they're afraid to email me. You know, if you have a question, email me. If you have a concern, email me. It's okay. I do prefer email as primary contact, but it's okay. You know, I don't want to be, you know, it wasn't from any of you, but I want to say that to the other classes too. Look, everybody's busy, you know, so it's okay. You know, I hope I don't come across like I'm unavailing. So, anyways, all right, benzos. Did you get your barbiturates and other IV hypnotics lecture yet?
No.
Okay.
Yes.
Oh, so like was it like reporting from the previous year?
Or maybe.
And then opioids?
That's where I would go.
Oh, no,
That's coming up?
That's more like it's. Yeah.
Yeah.
It did talk about our, like, in February.
Yeah, I mean, it's no, that's today.
Right.
Um,
No, he's doing this.
and this particular slide, it says benzos and barbs, but it's really just benzos.
What did you say?
Oh yeah. No point laser point.
So it just absorbs the light, right?
I use the right cable.
Sure. Thank you. Oh, I didn't want to take this class.
There is a zombie run that the upperclassmen did last year, and it was really fun. Everybody had a good time. However, I will say this, that it's right before FANA, and it's also the 26th, which is the night before our principal's exam and our Part A exam. But if anybody is interested, I think that it wouldn't be completely a bad idea to not cram the night before and do something fun. I mean, I can make an argument for why that would be good. So if anybody's interested, let me know. They have like zombies like all around.
Yeah, it's a lot of fun. A bunch of us did it last year. Dr. McDonald was a zombie actually. Someday I'll include a picture of that in my slide somewhere. Just out of the again. But I'll be a fan. I get there that day. Those of you who have exams the next day. The FANA starts on Friday, so you just come in late.
Yeah.
Gotcha. Okay. All right. Are we good now? Yay! All right. So benzodiazepines. We'll talk about them. We'll talk about some receptor theory. I love talking about receptors. Stuff like that. Okay. So now there's differences in potency between different benzodiazepines. For example, 10 milligrams of Valium or diazepam is about the same, equally potent to 0.5 milligrams of Xanax, alprazolam. Yes, whenever you see a lamb in the name, that's a benzodiazepine. They also differ a lot in speed in which they are metabolized and eliminated from the body. Half-life, time it takes to remove 50% of a drug from the body after a single dose. The half-life of Valium is 36 to 200 hours, depending on the person. It takes a long time to get out, but it's duration of action is not nearly that long. The man was just coming out of anesthesia after a series of tests in the hospital. His wife was sitting at the bedside. His eyes fluttered open and he murmured, "You're beautiful." She was flattered. Later, he woke up and said, "You're cute." And she said, "What happened to beautiful?" And he said, "The drugs were wearing off." Not a very nice joke. Take that out. So, but anyways, all right. A little hyporeactive, hyperreactive, or idiosyncratic. Remember those? Did you get any questions on that this time? Yeah? Yeah? Yeah, I'm farm. I don't do the exam anymore. So, notice with all of these, now let's take this away for just a second. With these three structures, there's some similar base structure here. Diazepam, lorazepam, and then midazolam here, and then we got a slightly different here. And then flumazenil, also see that there's some similarities. Flumazenil is the antidote, the decoy per se. Also, notice midazolam specifically. It is unique of all the benzodiazepines because as opposed to it just being an unionized form, it's highly ionized when the pH is less than 6. Because, not ionized. Okay? It's not ionized, it's just water soluble. This particular structure is much more water soluble than this one. And it just actually undergoes a chemical change when the pH raises between 4 and 6 and beyond. And that becomes very clinically relevant. What do benzodiazepines do? They bind with high affinity to the benzodiazepine binding receptor sites in the CNS, particularly the cerebral cortex. They are closely associated receptors with the gamma-aminobutyric acid, which transmits inhibitory messages from one brain cell to another. So, what is a neurotransmitter?
Carrier.
In general.
Transmits a message across the synaptic cleft.
Okay, and that's the main thing I want you to get, is we're not talking about a hormone that can be excreted one place, carried somewhere else, and then does its things. We're talking about something that happens at the synapse, neurotransmitters. And so, we can think of all sorts of neurotransmitters, norepinephrine, serotonin, dopamine, on and on. There's tons of them. There's lots and lots of neurotransmitters out there, most of which are quite excitatory. That doesn't mean that they are excited. What does excitatory mean? What?
Sympathetic response.
No.
It causes the cell to depolarize.
It generates an action potential.
They encourage something they cause something to happen. As opposed to inhibitory, which prevents something from happening. Okay? So more often than not, a neurotransmitter is excitatory. GABA, gamma-aminobutyric acid, is not. It is an inhibitory neurotransmitter. Now, you already had your lecture on IV anesthetics. What is the mechanism of action of propofol? It enhances GABA. What is the mechanism of action of a barbiturate? GABA. What is the mechanism of action of C2H5OH? Ethanol. GABA.
Yep.
Right? Okay. So pretty much anything IV that we give that causes you to zonk out, more likely is a GABAergic drug. Inhaled anesthetics, different, totally different. They don't work on GABA as far as we know. We don't really know how they work. So GABA, however, keep in mind, all the drugs I just mentioned, they're not GABA. None of them are GABA. Benzodiazepines are not GABA. They enhance GABA's effects. GABA is already there. Okay? So GABA is the endogenous ligand that exists in our body And it works well, but it works much better with its helpers. So GABA receptors are on the opposite outside of the receiving neuron that opens a channel, allowing chloride ions to pass inside the neuron into the postsynaptic cells. Those negative ions supercharge the neuron, making it less responsive to other neurotransmitters. Let's just look at some pictures. So here we have a synapse, a synaptic cleft. This is a synapse right here. We have a presynaptic neuron and a postsynaptic neuron. The way that all works is something gets released here that tries to get something to happen here. Any excitatory neurotransmitters that are involved in this will cause a potentiation of the signal. Anything that's inhibitory will try to stop it. All right, so we have all this gamma aminobutyric acid that's stored in the presynaptic area. When it is released, it binds to the GABA receptor, which is associated with a chloride channel, causing something to happen or not happen. Now, is it really?
Yeah, look at my pictures. I'm so excited because I drew cartoons.
She has some.
We should put it in our refrigerator.
Right?
Well,
It's like you're
I have a real test for nerd card here. Or your ticket spot.
I've never seen Star Wars.
Okay. Anybody ticket spot?
No?
No?
No, not
Yes.
I've never seen Star Wars. Yes, they were bought the first day. She looks like she's going to cry.
We've already discussed.
All right. Next nerd question. How many people have seen the latest trailer? Good trailer, huh?
Yeah.
I'm like, okay, I think I am.
Yes.
I'm getting all the flags.
What? What is it? Is it bad that you bought?
I'm just not taking.
No.
I don't find that spicy.
It's nice to see there are other nerds.
Yes.
Yeah.
Oh, there's Johnson, Alexis Johnson. You gotta talk to her. Oh, well, you're good. Have y'all had then you've had the Star Wars conversations? Yes.
Many times.
Yeah, I figured. Yeah, she's serious. Okay, so all right. What am I drawing?
Propagation of an action potential.
An action potential for what kind of cell?
It looks like a cardiac attack.
More specific. Because I'll draw another cardiac cell action potential.
Oh.
Anybody know?
Pacemaker?
That's a pacemaker action potential,
That's
right?
interesting.
Myocyte.
Ah.
That's correct. So the cardiac muscle cells have this action potential. This is the action potential you've been shown all your career. Ever since in school and all, every time they show this to you, every time they show an action potential, it's showing this one. Anybody know the most common action potential that occurs in the body, what it looks like? That. Almost vast majority of all action potentials in our body look just like that one, with a lot better picture. Because I can't draw well. Never do well in that. The thing is, that one's not very interesting, especially when you're doing like ACLS stuff and all. When we do ACLS, we talk all about this guy right here. And anybody can talk me through this one? What's this first part? What phase is it called?
Is it 0? No,
Phase
fast-
0.
Fast sodium.
Phase 1, 2, 3, 4, right?
Yeah.
And what's happening here?
Fast sodium channels.
Sodium channels are doing what? Opening or closing?
Well, they gotta open.
Okay, so this is where it gets fun. All right? This is where you don't have to memorize it based on what I've already taught you. So let's stop a second and ask ourselves, what are we even drawing here? What is this a graph of? Voltage.
Electronegativity.
Voltage, okay? So the y-axis is voltage. With this being a value of, let's say, negative 70 millivolts, for example, all right, meaning if it goes up, what's happening to the voltage?
It's going towards
It's
zero.
becoming less negative, okay? So negative 60, negative 50, it never gets to zero. It's always got a negative charge. So which is why we call it depolarization, because the voltage is, this negative 70 is a polarization. We are not normal, we're not neutral. We're opposite of neutral, we're somewhere, you could be polarized and be positive. Our cells don't exist that way. But it's that we're polarized, and because we're becoming more neutral, we're becoming depolarized. That's why we use that term, depolarization. So, I just said that the sodium channels are something. Oh, we said they're open. Okay, so if they're open, what's happening to sodium? They're going into the cell.
Right.
What charge do sodium ions have?
Plus.
Positive. Would that make sense? Is
Yeah.
the charge becoming less negative? Yes, because pluses are going in. Or let's say you couldn't remember if that means that the sodium channel is open or closed. Well, if you know this diagram, and you know it's becoming less negative, well, pluses must be going in, or what else could be happening?
Negative.
Minus is going out,
Yeah, negative's leaving.
right?
Yeah.
So one of those two things have to happen for this to occur. So if we know sodium is the ion involved, and we know that it's becoming less negative, pluses must be going in. So, well, sodium channels, when sodium channels are open, pluses go in, so the sodium channels must be opening. Which is why whenever you look at any, like, how many of you have looked at this before, and you're like, oh, sodium's in or out? Which way is it? Chloride's going in and out. Potassium's going in or out. Calcium's going in or out. I can't remember. And then you look at one source and it looks like it's one way, and then you look at another source. How anybody had that experience where two sources said two different things? You don't need those sources anymore. As long as you know the ion involved, you can figure it out. Let's see. So when we get to phase one, it starts coming down. Anybody know what ions involved here? Chloride. So chloride gets involved here. If it's a negative, it's causing it to become more negative. So what happened to the chloride channel? It opened, right? Because where's most of the chloride?
Extracellular.
Extracellular. So negatives are coming in, right? So you don't need those dang things that say if it's more or less, right? Coming in or out. What's involved here?
Calcium.
Calcium. Calcium is serving to keep it from coming straight back down. If it wasn't for the calcium channels being involved, it would look like this, right? So we have that plateau phase, calcium. Well, so calcium's preventing it from coming down, is keeping it in a less polarized state. Which way does calcium flow when the channels are open? In. So do you think the calcium channels are open or closed in this state? Open. See how that works? When you get to nodal tissue, this should be, yeah, actually that's about right. Anybody ever seen anything like this? So, when you get to nodal tissue, you got like sodium a little bit and calcium a little bit, and then you got a lot of sodium here, and you got some chloride, and you got some potassium involved here, and that kind of thing. Actually, potassium is involved through it all. But as this is coming up, where do you think is happening to these channels?
Open.
They're open. Very little, but they're slight opening. They reach a voltage-gated window where all of a sudden more sodium channels open, and you get it to go up much faster, and then it comes back down here, and potassium is actually all of this. Potassium, all of this. It's just potassium leak channels are involved there. That's another thing altogether. Well, let's now go back to this. Like any CNS dipolar action potential looks like this. Skeletal muscle looks like this. A neuron, which would be, like peripheral nervous system, sends a signal, muscle contracts. So, we got sodium is the big dog here. What do you think's having a sodium channel? Opens. Chloride is here. What do you think is happening in the chloride channel? Opens. So chloride opens here, bringing it back down. Where's the sodium potassium pump come into all this?
It's against the gradient.
It's against.
It's continuous. It's not like all of a sudden the sodium potassium pump now kicks in. Sodium potassium pump is a continuous thing. Okay, so the alterations to the resting membrane potential, which is this part right here, this line here, when we do this stuff, that's not pumps, that's channels every time. Okay, so, all right, now, what happens right here is we hit a point where we call it threshold. So there's a slight uptick there. You can't even see it here, but there's this point where you have this resting membrane potential where it's just staying there at negative, let's say 90 millivolts here. A lot of times that's closer to what it is for like CNS or like that. Negative 90 millivolts. It's just sitting there, and all of a sudden some stimulus comes by and it affects that resting membrane potential to the point where all of a sudden sodium channels that are voltage gated, meaning when they reach a voltage, maybe like negative 68, I'm just throwing out numbers, or negative, 88 or whatever. I don't know that that's the number or whatever. It reaches that point and the sodium channels open and fully open, and that's why you get the depolarization. What would be another gate besides a voltage gated?
Ligand.
Ligand gated. And what's a ligand? Well, they don't have to be endogenous. Some kind of molecule
Stimulates.
that does something at that receptor. So neurotransmitters are ligands. Drugs can be ligands. All sorts of things can be ligands. So ligand-gated channels open because that ligand comes and does something to the channel. Voltage-gated channels open because of a change in voltage. Okay. So what happens when my brain tells my eye to blink, what's happening is these stimulations are coming down, causing a reach in voltage, and the sodium channel opens. Oh no. All right, so this is what's normal. Oh, no. And we have that threshold. We have that spot where you reach that voltage where the channel's open. Okay. So if we don't want this to happen, if we're trying to prevent this from occurring, there's a couple things we can do. We can block a sodium channel. An example of a drug that does that?
Amiodarone.
Amiodarone doesn't work on sodium channels. I don't think so. Yeah, let me know if I'm wrong on that, but I don't think so. Lidocaine, right? Local anesthetics are sodium channel blockers, right? So we can block those sodium channels. It doesn't affect the threshold. It doesn't affect that they, when they open. It just keeps them from opening. So if you have you have this impulse of pain, and you have enough sodium channel blocker, that's what happens. That right there. Okay? And you don't get all of this. And you don't go, ow. Okay? Now, what else can we do? We could affect this point. We could raise threshold. Make that you have to have a bigger impulse to cause the channel to open to begin with. This is what we claim benzodiazepines do. I'm sure you've heard that before. Well, we gave them Ativan because they're having a seizure, and Ativan raises the seizure threshold. That's actually incorrect. That's the jargon we use, but we don't affect threshold at all with benzodiazepines. What else can we do? What we really want to do, if we don't want those channels to open, is we want to increase the gap between resting membrane potential and threshold. raise threshold, or what if we can lower resting membrane potential? So now it takes a much bigger impulse to reach the same threshold. How can we do that?
Change the concentration of electrolytes.
Yes, that can do it, changing the concentration of electrolytes. Another way that's relevant to this class, the lecture today, is to affect a channel. So what if we take a chloride channel? When it's open, what happens to chloride? Goes into the cell, which means an open chloride channel will do what to this line right here? Raise it or lower it?
Should lower it.
Lower it. Or what we call hyperpolarization. Remember, depolarization means a movement towards neutral. So you wouldn't say hyperdepolarization, right? Because that would be like extensive depolarization. We are making it more polarized. And by doing that, we increase this gap right here and make it take a much bigger signal to wake the patient up, get the patient to respond, get the patient to be scared. Like the anxiolysis that we cause with benzodiazepine. So, back to the picture. Benzodiazepines come in. They get on this receptor that GABA is already going to bind to. And when they work, what they do is they actually open chloride channels. So a lot of drugs we give close them. These drugs actually open, but cause an inhibitory response in the body. So benzodiazepine's mechanism of action is to enhance GABA by opening chloride channels, causing an influx of chloride, and therefore a decrease in the voltage of the resting membrane potential.
You want to say that?
It's recorded. If you want, I'll probably say exactly the same time this way. Benzodiazepine's mechanism of action worked by enhancing GABA, which causes chloride channels to open. Therefore, you will have an influx of chloride ion, which lowers the resting membrane potential, keeping the cell from depolarizing. So you have already gone in 30 minutes from, yeah, that Ativan works by raising the seizure threshold to this. It's cool. So benzodiazepines, and I promise you, if you remember to half this detail, you'll know it better than just about anybody in the hospital, including those anesthesiologists back. Like they know so much more than you. So, anyway, so here's your channel. Here's a bunch of proteins that allow binding of different stuff like GABA, ethanol, benzodiazepines, barbiturates, propofol even. And that's such a better picture. There you go. These are all the locations of GABA receptors. So what do you see that's common to all of them when it comes to the nervous system? They're all part of what nervous system? Central. No peripheral nervous system on that list. Okay. As far as what effects they have, the effects are directly related to the number of receptors that are occupied by benzodiazepines. And it makes a lot of sense. You're probably not going to get unconsciousness before you get anxiolysis. You're definitely not going to get unconsciousness before you get sedation, right? So if 20% of them are occupied, you're going to start seeing some anxiolysis. And that's what you'll see in your patient when you give it to them, and also they go, oh, okay. Which, that's what you're hoping to get out of them, right? and then you have to block all the family members. So this happens all the time when you give midazolam to a 16-year-old. Mom wants to ask 3 questions right after that. So, son, that thing I found in your room. You know, no. Sorry, I'm not gonna let you ask, and he doesn't have to answer. I have actually had that happen. Yeah,
They know it's pretty serious.
when mom tried to interrogate the son, and I said, "No, time to go to the operating room. I'm not going to be blamed for this one." I probably really blew a real opportunity for mom there, but for a moment, I just said, "Oh, my duty's to patient here." So,
She can potentiate GABA at home by letting him have, some of her.
yeah, some of that stuff, right? Anyway, so anxiolysis, as they get more and more receptor occupancy, you'll get more sedation, and then eventually unconsciousness. It is possible with benzodiazepines to achieve unconsciousness. It just takes a lot more than it does to get the other, like anxiolysis, whatever. They possess a much greater separation between the dose that produces the effects you want and the dose that produces death. What do we call that? Therapeutic index, therapeutic window, yes, right? That makes it a rather safe drug. Not to abuse, but to use. And that's why benzos have been used so much, both by us and by patients at home. Not that there's not problems with that, but it's not like when a patient is given a prescription for Xanax, the prescriber is really worried it's going to kill him. So cause other problems. It produces anterograde amnesia, meaning nothing that you just did on accident, will be forgotten. You can't use it to fix what just happened. Like if you accidentally, I don't know, do something really crazy like drop the patient when we're trying to move them the stretcher to the bed, crap, they fell. We want them to really think that they just got a bad hip, but they actually just fractured it. Let me get some Versed so they won't remember this just happened. Doesn't work that way. But after the drug has its effect, from then to the point where the drug doesn't have its effect, it can produce that amnesia. Which is why a lot of patients say, I don't ever remember going to the operating room, because they got Versed before they rolled back, and then they were asleep during the case, and then they woke up in PACU. So, no, surgery's over? What? No way! I've had that. It's the craziest thing, They're like, why do you're like, okay, how you feeling? I'm fine. Okay, well, all those are no way. It's over? Yeah, you're missing a leg, but just kidding. But no, it is. There are some things that we do that's really kind of cool. When you sit there and watch them go from wide awake to what we do to them during, and then like as if nothing ever happened at the end. You don't always hear that, but when you do, and you get that patient that just is like in PACU, wide awake, feeling great, and you know that it's really just maybe half the patient and 10% your great anesthesia. You just smile and wave and say, yeah, thank you very much. That was my patient, yes. No. Halfway facetious on that one. It is fun though. You do feel good. So, all right. So we know that a drug's distribution depends on all of those things. And that the vessel-rich group receives a large amount of the drug compared with the vessel-poor group. And when it's protein-bound, it's unable for uptake by an organ because it stays bound to that protein. We're talking about plasma proteins, then it stays in the plasma. And guess what? Especially depending on the dose you're giving, redistribution is from that vessel-rich group is responsible for the termination effects of the drugs. Especially like when you think about like midazolam or anything that you're giving potent enough dose that you're getting a significant effect. The bigger dose you give, the more you're going to see that redistribution because you get the big bolus to the brain that can then unload, right? So the reason why I stress that is, even though this is not something I would think I would ask you or Dr. Sub would ask you, but If you think about it, if you take 1/4 milligram of Xanax, you're not going to get a whole lot of effect of that. You're not going to have the determination of the effects that you do get, probably more going to be a matter of your metabolism, that kind of thing. If you take 5 milligrams of Xanax, which would be an abusive level of Xanax, you're going to get a significant effect, and then that duration of that intense effect will be shorter than the other example, because you are going to have some redistribution occur. Better example is midazolam. You give them 4 milligrams of midazolam, and they go, when they were screaming, 3-year-old kid, and all of a sudden they're like this, but then 20 minutes later, they're coming around and they're kind of waking up and that kind of thing. It's not metabolism, that's redistribution. See the difference? So, all right. You notice. All right. So, CNS actions: sedation, hypnosis, amnesia. These are not in any particular order, as you can see. Anticonvulsant, lowering the resting membrane potential. That's how it really does work. With all of these, that's really what's happening. Anxiolytic and central muscle relaxant. So here's the thing. When you're in the operating room and someone, your CRNA says, so how does benzodiazepine work to prevent a seizure? And you say, well, it lowers the resting membrane potential. Like, we'll look at you funny. I'll say, no, it raises the seizure threshold. And this is the moment you have to go, how do I respond to this? Option number A. Actually, wrong. Option number B. Oh, you're right, I was wrong. Option number C, something a little more diplomatic, like, okay, all right, I think it might be the way I was taught, but like, okay, I'll take that under advisement, and thank you, or something like that, in a very non-sarcastic way. C's probably your best bet, okay? Just saying. And if any CRNA then presses and says, I don't understand, like, you think it's different, can you explain it? Then you kind of have more of an open avenue to talk and say, well, this is the way I understand it, and and then you can maybe have a very good conversation about it. But you have to judge that very closely, especially on things that are more what I would call academic issues. It's one thing when you're told something that is going to directly affect your patient. Like, we're not going to reverse this patient from muscle relaxant. I know you haven't had that yet, because they have 2 twitches. And that is an absolutely insane, by the time you're where you need to be, you'll know that's an insane concept. That would be unsafe to that patient or whatever. That's when you might want to be like, I don't understand, can you please explain? Because my understanding is if they only have 2 twitches and we're going to extubate this patient, that one may not be unsafe. Can you please clarify what you mean? Maybe I'm misunderstanding. That would be an appropriate response. But on something that's more like academic, just leave it alone. Okay? Oh, central muscle relaxant. So this is classic. I give patients a Versed. We go to the operating room. Can you please move over to the stretcher? From the stretcher to the ORT. And they go, sure. Man, I feel like my butt's full of lead. And they feel like they can't move. They struggle to move over and that kind of thing. We'll learn all about muscle relaxants soon. And I'm talking about like rocuronium, succinylcholine, that kind of thing. Those things keep all muscles from moving except for like cardiac muscles and that kind of thing. Which is funny because the movies always portray that. I can't do a paralytic and the patient's still breathing, right? Or they can flutter their eyes or whatever, like Law-Abiding Citizen. Seen that movie? That one scene, well, he's still breathing. Or my favorite of all time, by far, this goes back to the whole good doctor thing I mentioned to some of you earlier today, is ER watchers? ER watchers? Okay, so I started watching ER before I was involved in healthcare. And halfway through, I became a nurse, kept watching it, was in anesthesia school probably about the time we're getting to the last season. I kept watching it for a while just because I was into the characters, but it's the only medical healthcare show I've ever watched because the rest of them I can't handle. I just can't. I can't. Oh my gosh, you know. Which, by the way, there was a survey done once by residents, like surgical residents and like medical residents, about which show they prefer. Do you know what the #1 by far show was preferred by the surgical residents? This was done like 5-7 years ago.
Great.
Not great. It was like the bottom of the list because Grey's is full of crap. But anybody know? Scrubs.
Yeah.
Scrubs.
Yeah.
They love Scrubs. Why? Because Scrubs doesn't try to explain anything. It's just funny, right? You know what I mean? But anytime they try to, any show that tries to explain it, oh my gosh, please just, you're killing me. You're killing me. So.
I figured they love Grace because it makes the doctors look like they do everything.
Oh, well, that. But a lot of them do that. I mean, a lot of them do that. But I mean, the little bit of Grace I've seen, it's, when they try to go technical, it's bad. It's just bad. The worst one, in my opinion, is House. I mean, really, really bad. But back to ER. So I'm now an anesthesia student. You'll appreciate this. Maybe I should say the story, but I can't help myself, so I'll tell the story now. Everybody remember Luca? Luca was the, I guess the girls called him the eye candy physician. You know, he's from Slovenia or something like that, Bosnia. And so, almost the same place. No, he is Bosnian. That's right. Because he came over because all the yes. So there was that one nurse who I think her name Abby. No. I forget. It's been so long. Well, anyways, she had a son, and like her husband was a bad guy, and anyways, so there's a robbery or something like is going on. It's been too long. I can't even tell the story right anymore. They're in the hospital, like in an ER bay, and Luca's in there, and one of the guys, like her husband, like their ex-husband or whatever, and the other thug that was there, stabs Luca in the back of the neck with a syringe or something. Anybody remember this scene? No? And she goes, "Did you just give him Vecuronium?" And they go, "I don't know." And she goes, "Yes, you just gave him back." So he, of course, falls immediately to the floor, which is already #1 wrong. And he's laying there, and then they do it so right. I mean, she's like, "Well, we can't just leave him. He'll die. He can't breathe." Okay, now Vecuronium is a muscle relaxant, so it paralyzes every muscle, like including respiratory muscles. Okay, so yes, that part's accurate, although it would have taken about 2 minutes, 3 minutes for him to get fully paralyzed. But he's laying there, and this part they did so right. She intubates him. No, she's got a laryngoscope, she's got an endotracheal tube, and they even get this part right. She's saying to him, "I'm so sorry. I'm so sorry." Like, and they're portraying this right, because he would be wide awake while this is happening. He just can't do anything about it, right? And I'm like, wow, this is pretty accurate. She puts the endotracheal tube in, and the guys are like, "Okay, let's go." And she goes, "Okay." And they leave. No ventilator. And I'm like, I mean, I was going to be so impressed. I was going to be like, wow, that was amazing. They actually got that one right. I mean, that was pretty much how it go down, you know. And yep, just the tube in the mouth just totally did it. I mean,
Were his eyes open?
I can't remember.
Did he have oxygen source?
No, I mean, he just laid there with an endotracheal tube, and of course he survived because she saved him. Yeah. Let me just tell you right now, if you paralyze a patient and you intubate them and don't ventilate them, they will die.
Save yourself,
Yeah, I'll have to. So, but anyways, but I see that in a lot of different movies and that kind of thing where someone's given a paralytic, but they are still able to breathe, maybe even blink their eyes or whatever, you know. So yeah, it's just like, oh jeez, you know. Anyway, where did I go from that? Okay, as opposed to all that, benzodiazepines work as a muscle relaxant centrally. It works on the central nervous system. So the reason why the patient has trouble moving to the OR table is because the signal from the brain that's trying to tell the patient to move isn't working very well. But it has nothing to do with paralysis. Okay? It's a central muscle relaxant. So what are the risks of sedation? Well, depression of airway reflexes, there's an individual variability, and I have seen that, and it's not just about how old or how big or anything. I mean, those things are factors, especially the age thing. If you got a 90-year-old lady and you give her 2 milligrams of Versed, well, you probably don't need a whole lot of anesthesia, just saying. Whereas some people, you give them 2 of Versed and nothing at all. But even when you look at the same age, same everything, and you look at that patient, some patients, 1 milligram of Versed will have the same effect as another one 5. There's a lot of variability, yeah.
Is there any correlation, or can they even measure like how much endogenous GABA you have, or depending on how many GABA receptors you have?
Yeah, I mean, there could be some upregulation going on in a particular patient. Maybe they're on something already. There's all can be factors, but you just, when you go visit that patient in a pre-op, there's not a whole lot other than age, medical history, drugs taken, all like that. That's going to give you a really big clue as to who is going to be, yeah, you can have a general predictability. I mean, there's certain people in this room that just looking at them, their body type, body size, or whatever, and their age, that I think they're going to need more than another, but that they'll be the ones that fool you, is what I'm saying.
They gave me 4 milligrams.
4 milligrams per you? Oh, they did? Is that what you said?
Yeah, 4 in pre-op.
Uh-huh.
Going back.
And?
Push 4 milligrams. That's all I remember.
That's all you remember?
I was like, I don't need much.
Yeah. And so who knows if 2 milligrams would have had that effect? Be careful to ever promise a patient that they won't remember going to the OR. Or if you're going to do a very light MAC where you're only giving Versed, to promise amnesia. Because if you say, yeah, you won't remember anything, and you're like doing an eyeball case and all you're giving is like 1 of Versed, oh yeah, I had awareness. I remember the whole thing. They told me I would. You know what I mean? Careful what you promise. So even when I'm going to give someone 2 to 4 milligrams of Versed, I say, many people don't remember going to the operating room. You may or may not, but it just kind of takes the edge off the whole thing in case it's not something if you don't get up in the morning and go, I can't wait to get in the operating room today, so anyway. So my favorite is though, the label for Versed is orange, and the label for fentanyl is blue, and I just kind of flash and say, Gator fans? Gator fan? So anyways, all right. I'm trying to use my laser pointer. Just doesn't work on these screens. There's interactions with our medications. There's allergic responses and cardiovascular decompensation. But that takes a lot of drugs. So one of the things I think is important in the pharm class that you really categorize is effects on the brain vasculature of different drugs. Things like intracranial pressure, cerebral blood flow, CMRO2, like the metabolic rate of oxygen in the brain, which drugs increase what. And so it's really important that you synthesize that information, like comparing propofol to Brevitol, to benzodiazepines, to inhaled anesthetics, and which ones? Nitrous oxide versus halogenated ethers. Does anybody know? What do all inhaled anesthetics do to CMRO2? Decrease them. Does it decrease ICP? All of them?
No.
Which one does it? Nitrous oxide. See, this is the kind of stuff I'm talking about. How does that differ from propofol? What does propofol do to CMRO2?
I don't know. Probably.
Decreases it.
Yeah.
What does it do to ICP?
Probably.
Decreases it profoundly. As opposed to volatile agents like halogenated ethers, where yes, I said that nitrous increases ICP, but technically volatile agents have a nominal effect and maybe even a slight increase on ICP. So I might have misled you with how I asked the question a minute ago. So what does propofol do? It decreases both. Significantly, not a question. But so if you want to give a drug that's going to decrease ICP and decrease metabolism of the brain, propofol is great. So are benzos. But volatile agents, Nitrous, no. Those kind of things. Categorize them and kind of compare them, and so you kind of know. So, yeah.
So a question about that, whenever you're reducing the metabolic oxygen consumption, and you also decrease your CPP, like in propofol, where you're getting that,
Decrease CPP? Okay, so you're talking about raising ICP.
well, decreasing CPP from arterial
Okay.
hypertension.
And just to make this very clear, what we're talking about is cerebral perfusion pressure is defined as,
MAP minus ICP.
okay, MAP minus ICP. Okay, so you're talking about a decrease in CPP and a decrease in CMRO2.
Yeah.
Which examples of drugs that would do that significantly would be?
Propofol and
No, not as much. It depends. So you're thinking of the MAP part, but there's both that you have to consider, the ICP as well.
I guess.
So what's the worst ones to give?
um,
To decrease CPP,
nitrous because.
nitrous, and it's another drug that
Increases.
definitely increases ICP.
Increases?
Yeah.
Ketamine or?
Yes,
Ketamine.
ketamine, right? So anytime you're worried about that balance, those are the two bad guys, right? All right, so back to your question, sorry.
So if if you have a patient who has, a neuro deficit,
Yeah.
and you're worried about CPP, is it okay still to give propofol because it also decreases the metabolic
Right.
oxygen consumption?
And so this is where I'm going with my kind of hounding you with questions. You can treat increase in MAP. You can't so easily treat increased ICP, okay? So what drugs can we give that don't decrease MAP and are anesthetics? Very few, right? Benzos is a good example of one. It's not really the best anesthetic. If you give enough benzos to cause an anesthetic, you're gonna have, then the neurosurgeon's gonna be upset that they're like for hours and days, right? Okay, so ketamine, well, that's already a no-no for neuro. Nitrous, already a no-no for neuro. The rest of them all decrease peripheral vascular resistance and MAP, right? So propofol, other drugs, sevoflurane, all of them do. So, but we can at least treat that with norepinephrine, ephedrine, or epinephrine, norepinephrine. We can treat that. It's just harder to treat ICP. So if you say, well, I'm going to use nitrous because it won't have as much effect on the MAP, well, you got the other part that's hard to fix. But I can use propofol and fellow. See what I'm saying? Mm-hmm. So when you think of CPP, you got to think of what can you control. So, okay. Did I even come close to the question though?
Yes, yes, that was what I was asking.
All right. So, benzos decrease ICP and cerebral blood flow, and also cerebral metabolic consumption. So, it's a very friendly to the brain drug, as is propofol, as is thiobarbiturates. Like the gold standard one was thiopental. It's not made anymore, but that was the gold standard. All right. The muscle relaxation properties are mediated at spinal cord level, not the neuromuscular junction, and there's no direct analgesic properties to benzodiazepines. Interesting enough, though, when I was talking about local anesthetics and all the crazy experimentation going on with adding stuff, one of the things that they test is benzos for like epidurals and peripheral nerve blocks and all. They'll add like some dazolam, or there's actually some studies where they're adding like remimazolam, which is not even marketed yet. It's not even, they're still in phase 3 studies where remimazolam is coming. Remimazolam is a benzodiazepine, and it's like super fast off. It like falls apart in the plasma, and it's going to be here, I think. But where they study giving that for enhancement of analgesia at the like peripheral nerve level or the epidural level or whatever. But in general, we do not think of benzodiazepines as anti-analgesic. Or that would be a double negative, wouldn't it? We do not think of them as an analgesic. Yes. So, right. Cardiovascular minimal CV depressant effects. That is definitely true. When someone is at imminent cardiovascular collapse, I have seen midazolam push them over the edge, but in general, it's a much safer drug for cardiovascular effects than just about anything else you can give. Which is, like I said earlier, just a minute ago, yeah, if you want to be brain friendly, you can give midazolam anesthetic. Just be for hours, days, you know, because the amount of midazolam you have to give is going to take for a long time to get it out. So, all right, respiratory depressants, failing responses to CO2 is dependent on which benzodiazepine is administered, the patient population, and this is the big one, concomitant administration of other anesthetic agents such as opioids. Big point here. All right? You give someone to a Versed in pre-op. If they go apneic, that is crazy. It just doesn't happen. Now, I've seen, especially on older patients, I've seen them like get quite sedated from 2 milligrams of Versed. So where you're like, Alfie, wake up! You know, I mean, I've seen that. But apneic? No. But you can take someone who is rather sedated on a benzo, add a little bit of opioid, and when that same amount of opioid would have never done that. So they're very synergistic in nature. So you have to be careful of the two together. So adverse actions are all the ones there. One I do want to kind of point out that's kind of interesting is sometimes you'll get like this opposite effect thing, where you give Versed and they get kind of hyper and hyper freaked out. It's rare, but I've seen it. It's almost, you'd almost call it idiosyncratic. I mean, where they just kind of rev up. So that can happen, but usually that does not. The only time I've ever seen is in younger people too, like teenagers, young adults. Elderly, they're certainly more sensitive, so you have to be more cautious. There's a slow drug absorption rate, so therefore decreased metabolism. There's an increased percentage of adipose tissue in the body mass, so they hold on to it longer. Drug accumulation rate occurs because they have less plasma proteins. All sorts of reasons. So regulation of use of diazepam, alprazolam, lorazepam, temazepam, triazolam have been reported. There are lots and lots of cases of abuse. A lot of times they'll use it as to get that synergistic effect with opioids, or alleviate withdrawal symptoms from other drug abuse, alcohol detoxification, like self-detoxification. And if you do high doses, you can get that high. So this chart shows, the alpha phase of the two-compartment elimination curve. The distribution half-life, meaning how long does it take for the drug to get to where, to reach equilibrium. And I can't remember now. I know that this one is PO, because I thought, that's awfully long. This is for PO diazepam, which oftentimes diazepam is given PO. But these are, I believe, IV. You can see the elimination half-life, the really short one, relatively speaking, is midazolam. The elimination half-life of remimazolam, which is the drug I mentioned a minute ago, is like 5 minutes. It's going to be amazing.
To go same thing as they were fentanyl, ester hydrolyzed.
So what they're trying to do is play off the name remifentanil.
Okay.
So the thing about remimazolam is I'm not sure how much we're going to use it. It's going to be an infusion drug, and you know what journals are talking about it the most? GI journals. I think with the angle is we don't need those propofol people anymore with this drug. We'll see. We'll see. They may be right. I hope they're not right. So, anyways, but it'll be like the next political thing, like who can push it, who can infuse it, and at what dose level, you know. And of course, we'll all say, we'll be united with the ANC and say, anything more than hello effect, They really need us, you know. The whole thing, you know. We always tell the truth exactly what we think, right? Never do we think about money or job security, right? It's all the other ones mislead.
I'm always.
We're guilty too. Oh my gosh, we're recording. Okay. At least I'm being transparent. Okay, protein binding. Notice lorazepam is the least, diazepam highly protein bound, and guess what? Diazepam has a massive volume of distribution. Massive volume of distribution. Because it's highly lipid soluble.
Right.
So diazepam is that prototype. It's mostly used for anxiolysis. It's highly protein bound. Only 1 to 2% of it's free, but boy, that 1 to 2% is highly effective, and it's still got a high volume distribution. It's also, you need to know, it's unique because it has an active metabolite, as does midazolam, but much more powerful metabolite. I mean, not to say desmethyldiazepam is as strong as diazepam, but it does have some effect for sure. And so you'll get that second peak effect with diazepam where you give it, and then later on, as the patient seems to be coming out of it, they get a second effect, and that's that accumulation of desmethyldiazepam. It's not suitable for induction agent because there's a lot of pain on injection because it's prepared in propylene glycol, antifreeze. And also the induction course is unpredictable, and it's a delayed onset of induction. Diazepam also highly lipid soluble, large volume distribution. Effects are terminated mostly by redistribution. Anybody know what cimetidines trade name is? I wonder if that's finally gone. Is it gone? If somebody finds out that it's actually off market, let me know, because then I'll just take the bullet off. Because it should be. I mean, there's so many better drugs. Cimetidine sucks. It's a cytochrome P450 hog. It just takes it all away and causes all sorts of problems, you know. But anyways, but it binds to cytochrome P450 and so reduces the metabolism of diazepam. Heparin can displace diazepam from protein binding sites, causing a much increased effect. It can reduce the MAC of all agents by 30%. Okay, there's that second piece of peak effect that I'm talking about. So that PO onset 30 to 60 minutes, peak of 1 to 2 hours, elimination half time. This is elimination half time, not half life, which I gave you a different figure for that, is 20 to 50 hours. Metabolites in the liver, screening. Midazolam, onset 1 to 5 minutes, peak 20 to 60 minutes. I can tell you from experience that is not accurate, especially for IV midazolam. The peak, not the onset, but the peak number there is not accurate for reality. So maybe I got that from some PO dosing, something or there. By the time you reach 60 minutes, you think you didn't give them anything, typically. I've seen them where they have that peak in 2 minutes, and then 10 minutes later, they're already starting to recover. So I would not say that reality matches that 20 to 60 minutes. And generally, the duration actually is less than 2 hours. So I only put this in here because I thought it's so odd. I found this like 2 years ago, and I was doing some reading on benzodiazepines for this lecture, and I found this article that said the pharmacokinetics of midazolam in man. And I was like, I guess literature used to talk like that. I mean, really, you know, it's kind of like where no man has gone before. Well, they would, instead of saying in humans or something, in people or whatever, they would say in man. And I was like, I've never seen that in any article before. But, you know, I wonder, and I can't remember the year this was published, but it's probably the 70s. Yeah, I was like, wow. Because that would be just such a uncool thing to say now, right? You know, unless you're talking about males, and then they would say in males, right? So, but this article was actually just about people, but they called them man. So I just thought that was wow. My dad would be like, "What's the problem?" Sorry, Dad. So anyways. So benzodiazepines and midazolam routes of administration. Generally, you're going to give no more than 5 milligrams IV. You don't have to give midazolam to a patient. Okay, they don't all need it. There is some literature coming out where we've always known about emergent delirium, but now they're starting to blame midazolam for it. I'm like, ah, son of a gun. That's why we give them midazolam, is to avoid delirium and craziness and them freaking out. But there's, I guess, some, I haven't read it all, but there is some literature that is kind of blaming the midazolam for some of that emergent delirium. What's really funny about that too to me is when someone does have emergent delirium, one of the things I give them is midazolam because they're like trying to get out of bed, they're going crazy, you know. It's like, well, that or Ativan or hard restraints, you know. I mean, because I know those little wrist ones ain't going to cut it, you know. So even in my practice, I've kind of moved a little bit away from like automatic use of midazolam. Yeah.
So kind of like when you're doing your windows on propofol in the ICU and like they're off it for not very long at all and they start getting crazy.
Yeah.
You start immediately reaching for stuff, so it's almost like a similar.
Yeah, and what do you do when they do that? You give them
Back up.
propofol, right?
Yeah.
So, yeah. So,
Bolus.
or you extubate them, right? So, it's just, sometimes you'll face the same thing. You're waking someone up and they get a little crazy. It's like, okay, which way do I go? Do I put them back down, or I extubate them hoping that they'll calm down? Sometimes one or the other is the wrong choice. And even something that comes with experience. Okay, so let me make this very clear. I say here that about a pH of greater than 4. That other slide said 6. So the thing is, as you go from a more acidic pH to a less acidic pH, there is a range. And so, and this actually shows it. So here's a pH between 2.5 and 5.5, and the percent of the open ring form, which is the water-soluble form of midazolam. So as the pH rises, you get less and less of the open ring form, meaning you have more and more of the form that works. Okay? And so you can see this is 10% here, so at a pH of 4, we're at about 4% of non-workable midazolam. And by the time we get to 5.5, we're at just, maybe 2% or something like that. By the time we get to physiologic pH, we're basically at almost 0, which is what makes midazolam nice because it doesn't rely on like a propylene glycol preparation to be soluble. It has this magic thing where as long as we make the solution somewhat acidic, it'll be very water soluble and it won't precipitate. So, and then you inject it in the body, it immediately mixes with 7.4 pH plasma and goes straight from the water soluble to the non-water soluble. Great. So it precipitates in the body. Is that what happens?
No.
What do you think happens?
Did-
It goes from a volume about 1 ml to a volume of like 5 to 8 liters. So it's okay. See what I mean? Okay. Yeah.
So I think my thinking may be backwards. So whenever I was reading about it, that it makes it more lipid soluble at physiologic pH.
Yes.
But you said you have less that works.
More than works at physiologic. This is a graph of what doesn't work. So doesn't
Okay,
work.
You said, I thought you said whenever we were going this way, you have less that works.
Less
Less that
open
never
ring.
mind. I was
Right, which is not.
I was like, wait, that doesn't make sense.
Yeah, right.
Okay.
So that allows for the aqueous preparation. It's a more effective sedative than diazepam, but much shorter duration. It's more potent, rapidly crosses the blood-brain barrier. It is not as affected by cimetidine because it's metabolized by the cytochrome P453A. So not as bad of a deal. It has 3 metabolites and only one of them has any effect at all and is mild. So we don't really worry too much about the metabolites having much effect with midazolam. So midazolam, if you look in the oldest literature on midazolam, you could tell that they were originally thinking induction agent. That was where they were going with it. They're like, hey, they're doing all these studies looking at inducing someone with midazolam and all, and you can do it. But it never really took as the induction agent. Before propofol, thiopental was the induction agent of choice, and then propofol just took thiopental right off the market. I mean, because for a while there, thiopental still kind of had the market on like neuro cases. Well, if your patient has high ICP, thiopental is the drug of choice until it was shown that, well, no, propofol is just as good. Okay, well, dang. What do we need thiopental for? Well, nothing.
Technically, I heard that it was made in Europe and that they did not want to send it to US anymore because they were using it for lethal injections. And so that's why it stopped coming to us, but it's still used in Europe because that's where it's made.
I mean, that might be one interpretation of why, and that might have been a factor. But the reality is, prior to it being off the market, nobody was using it. Yeah, so nobody was using it. Yeah, that's a good point. Like, what if it was being used excessively here? I don't know. Maybe the ethics get a little different then, So, yeah, I don't know. I don't know that the company that was making it said that's the reason. Now that might be what they even said in the press, right? But I don't think they're making any money off of here because we quit using it. I mean, in anesthesia world even, we stopped saying, okay, well, in this particular case, we'll use thiopental. Every time we think to use it, we go, why? Why would we bother? We have propofol. Thiopental was more CV unstable, caused more drop in the MAP, longer acting, so not as quick of a recovery. It just made no sense to use thiopental. So I'm surprised they're using it anywhere in Europe. So the propofol's cheap now. So yeah.
You know how you just asked, so if it's in an acidic state and then it's ionized there. Then
I misspoke earlier. It's water soluble. It's not ionized in this case.
Okay. Why is it not ionized?
Because there's no charge. It just undergoes this change, and when that ring opens up, it becomes a more polar.
So it doesn't work with the PKA.
This is not a PKA issue. Now, midazolam has a PKA, and there is, I think its PKA is like 11 or something like that, So it ends up not being an issue in any of this. But in this case, it's not about becoming ionized or unionized. It's about this conformational change. It goes from more of a polar compound to a more nonpolar in three-dimensional space, and that more nonpolar is less water soluble.
That's the open, right?
No, the nonpolar is the closed one that works in the body.
Okay. My question was actually about the local anesthetic class that you took the lecture.
Right.
So you had mentioned that sometimes we inject a local anesthetic into a highly acidic area, like I don't know,
Like a raging foot.
Yeah. So you mentioned that we use some bicarb, right? So how much? So it's already in an acidic bath, which causes it to be ionized, and then you add bicarb. Won't it precipitate?
Okay. So depending on the local anesthetic, like for example, I mentioned bupivacaine, it doesn't take much bicarb to precipitate. Keep in mind too that you're not going to add bicarb and then a year later inject that drug. Okay. So when they make those preparations, they make them designed for long-term longevity, including not precipitating, right? So if you're going to mix that bicarb and then 30 minutes later inject it, then you have less chance for other factors to, when you're at that balance, you're kind of closer to that threshold of a precipitate, right? It's not as likely to occur in a short period of time as it is way longer. This is part of why even like you have the Y compatibility versus the Lyell compatibilities and all like that, because some drugs, as long as it's not for long, they won't precipitate, whereas others will be right away. So I'm just saying that the reason why they don't make it a higher pH to begin with is either concerns about long-term it may precipitate, or it may affect the potency of the drug. Some drugs degrade in certain environments, so there might be other factors besides solubility.
I'm asking, like, when you draw, so we are mixing it
Yeah.
ourselves with bicarb,
Right.
That will cause it to precipitate or no?
If you give enough of it, yeah.
Okay.
So with
How do you
bupivacaine,
know
it doesn't
how
take much. With lidocaine, it would take a lot more. But if you kept giving bicarb to lidocaine at a certain point,
Well,
like we typically give 10% by volume. So if you're gonna have a 10 cc syringe of lidocaine, we're gonna have 1 cc of bicarb and 9 cc's of lidocaine.
and you know that.
And if you
works
do
in
that,
experience.
it's been studied at some point or whatever, and then they figured it was safe. And nobody's ever had a case report where they mixed 10 cc's or 10% by volume and had precipitate. So that's just kind of a standard you use. But so who asked me that earlier?
That's me.
Yeah. You know, I mentioned that I have a colleague that makes it for certain situations, making 10 cc syringe that need 2 cc's of its bicarb and doesn't get precipitated. So we're not even close to that threshold when we do 10%.
And also does that, I asked this because you mentioned like, oh, you're putting it in blood basically, and that's a huge volume of like 6 to 8 liters.
Right.
Does that have any effect to, you know, like, so you add some bicarb, it doesn't really make that much of.
No, yeah, like 2 cc's of bicarb would have very little effect on the overall plasma. And keep in mind too, when we're doing that, we're not giving it IV anyways.
Oh, yeah.
So as opposed to what I'm talking about here, we are.
Right.
Oh, I thought that's fine.
Well, thank you.
Uh-huh. And if you did give it IV, like let's say the lidocaine we give before on induction, there's no real good value to giving the bicarb anyways. It's weakly diluted to the pH of the plasma. So other uses, any benzodiazepine can have a PONV effect, but and not just from chemo, but it's more about just that rev up processes in the body that's going on in the mind. And so I've had patients that are kind of like anxious and PACU, and Ativan seems to also help with PONV in that case. Flumazenil. Romazenil is a trade name. There was a picture of it on that one slide with all the structures. It has a similar base structure to benzos. It is a benzodiazepine antagonist. You generally give about 0.2 milligrams slowly. 0.1 to 0.4 is generally the range you would give. Titrate every 15 seconds, up to 1 milligram if you had to. And it works quickly. When it does work, it works quickly. And it can wear off as soon as 15 minutes, but it can also last longer than that. You just have to know that you can't give flumazenil, fix the problem, and walk away. You have to continue to monitor the patient. So the only time I've ever given flumazenil was to a patient that anesthesia wasn't involved with. It was in GI lab. They called anesthesia and they said, man, we got this kid here. He was like, I don't know, 18 or something like that. And he just won't wake up. It's been 4 hours. We've given him Narcan, and he's just kind of sedated. Can y'all come? So he sent me over. Expert CRNA as opposed to anesthesiologist. I said, oh, they must be busy. I'm not sarcastic. It just seems like anytime there's something weird, we're not smart enough to handle it, right? You know, anyway. So they sent me over, and I got over there, and I'm talking to them, and you know, the nurses and all, and yeah, I mean, he just wasn't very arousable. He was breathing fine, and I said, well, how much, you know, fentanyl did the patient get? I can't remember, a couple hundred mics or whatever. How much Narcan? A couple hundred mics, something like that. Okay. And I said, did he get anything else? Well, we did give him bedazzling. And I mean, it's been 4 hours, and I'm thinking in my head, there's just no way. I mean, this should not still be causing a problem. But I was like, well, in the absence of other explanations, why not? So I told him to get some flumazenil. We gave 0.1 milligrams, and he started coming around almost right away. And romazicon does not work on someone when they haven't had any benzo. It's not like you can go say, man, I'm going to take some romazicon before my next test, and I'll be jacked. You know, it doesn't work like that, right? It only works in presence of benzodiazepines. Okay, so anyway, just tell you, don't pilfer it, So so that means that told me that the midazoline was the problem. So there can be those odd situations where it just does linger, which is maybe part of why the whole argument about the emergent delirium may be valid, because you said, it's been 4 hours, it shouldn't be. Well, with some people it is. It wasn't like he was 90 years old, he was a kid. And so I was like, wow, I didn't think that would work. But boy, do I look like a genius. Don't ever do that, by the way. I'm just kidding. Don't ever, Your first intubation, you can kind of give a high five, but don't forget to put don't forget to ventilate the patient. Like an ER episode, but in general, try to act like you've been there before. Try to act like you've won. Okay. So, but I mean, you all will be. You do need to have your little plan for. Okay, when I get that first intubation, what's going to be my celebration? Is it going to be taking my SO out for dinner, or what is it going to be? But it needs to be something special, something you remember. Hey, I intubated for the. Just try not to do the high five in the whole operation while the bed's going. You have any inhale CO2? No. Oh, I must have used it. No, you just didn't ventilate that. Yeah. All right. Okay, so next week.